Thank you all for being here, and thank you for the invitation to speak. The title says Pediatric IBD patients, but it really, much of what I'm saying will apply for our adult patients as well. My disclosures, I will be talking about medications, and pretty much in psychiatry and IBD, most of what we do is off-label, especially related to pain. So two objectives: how to prevent narcotic dependence and how to treat narcotic dependence. And the answers are a little more complicated than the questions. One day, Alice came to a fork in the road and saw a Cheshire cat in a tree. "Which road do I take?" she asked. "Where do you want to go?" was his response. "I don't know," Alice answered. "Then," said the cat, "it doesn't matter." Now, some days, especially now being involved with the IBD medical home with Dr. Miguel Reguero, about 30 to 35% of our patients are on chronic narcotics. So often my days can start like this, but luckily we do know. I put this slide in, though, because we know from the vast literature of treating chronic pain across other conditions, we really have little to no literature yet in specifically treating or preventing narcotic use in our patients. So I drew from much literature, and again, as always, to present this in 15 minutes is a challenge, but we'll see how I do. So I broke this down into a box of 4, whether we're thinking about acute or chronic pain. Chronic pain is anything longer than 3 months, which is on a constant basis, or 6 months with intermittent pain. And then whether you were dealing with acute or chronic pain with or without addiction. So what's addiction? An inability to consistently abstain from your substance, here opioids, impaired behavioral control, a craving, a diminished recognition of associated problems, a dysfunctional emotional response, often in our patients anger, and progressive and potentially fatal, I think is the most important point. If we don't identify abuse, addiction in our patients, it does contribute to their mortality by either accidental or intentional overdoses. Every day in this country, 40 patients die directly related to their prescription opioids. That's across the whole population. So what are some of the risk factors for adolescent addiction? So I'm going to build on what you heard from Dr. Kappelman. For our adolescents, you have genetic factors, so family histories of addiction, the mood disorders, and brain maturation. So it's a formative time for an adolescent brain. Their connections between their cognitive centers, their frontal lobes that help them make wise decisions, and their limbic centers, which is their emotional regulation, and their pleasure or thrill-seeking centers has not completely matured yet. So you actually are influencing development, and narcotics can really derail their ability to control impulsive, pleasurable behavior for a lifetime. So just something really worth pausing for our adolescent patients. Early drug use, whether that's borrowing pills from friends, borrowing pills from their parents, the availability. And then the environment, we know that kids are at higher use for abuse from chaotic homes, if they are themselves experiencing physical, emotional abuse, peer influence, community attitudes, and looking at their behavioral, their functioning, especially in school and social settings. So let's start with acute pain and no risk factors for addiction or aberrant behavior. So the common indication should be no more than 14 days. So this is after surgery, or if there's a very bad complication causing a lot of pain, perforation, and really to treat the source of pain as quickly as possible. But really no more than 14 days or 2 weeks of opioids is what's indicated. So when we're talking about considerations for acute versus chronic pain, obviously when you're having a really bad inflammatory flare, especially if there's lesions that go through all the layers of the mucosa, so especially in Crohn's disease, the nerves are sitting in those deeper layers. So that's when they get pinged, and that's experienced as extreme pain. Anatomically, obviously surgical incisions, but also strictures, adhesions, fistulas. Bacterial overgrowth can come with a lot of pain. Then the neurobiological, psychological problems. So pain does affect nerves. Nerves with enough chronic pain can change in how responsive they are, so they get sensitized to the pain, and then that in turn does start changing what happens in the brain at a chemical level, but also at an anatomical level. Neurons start changing how they communicate with each other. Psychosocial, we know that stress influences pain, and then genetics, it's in the beginning of investigations, but we're learning that there are certain genotypes that are more associated with a lower pain tolerance. So let's talk about acute pain when there might be an addiction problem. So we want to screen for opioid risk. We want to, if opioids are necessary for a surgery, we want to make that course especially brief, and we really want to actively treat the addiction. And we're going to talk about that as the last point. How do you treat addiction? I think the most important thing we can do in pediatric GI is prevention strategies. And a lot of that has to do with education of physicians outside ourselves. So the ER physicians, the surgeons who like to give 90-day supplies of opioids just without really even thinking, and even the anesthesiologists who often could be there educated to stop those kinds of prescription habits. So it's not all of these docs, but there's, including in Pittsburgh, a fair number that will just automatically give those longer prescriptions. And about 7% of patients with orthopedic surgery, adults who previously didn't use narcotics ever, were chronically hooked after their surgeries. So it's a beginning point of a problem. There are no randomized controlled trials to support narcotics for chronic abdominal pain. In fact, across all of medicine, there are 60 trials that support efficacy of longer-term opioid use in non-narcotic pain, and it's neuropathic and musculoskeletal pain, and even there with a lot of warning caveats. Educating our colleagues about the serious complications you just heard about, and then side effects in pediatrics, particularly vomiting, pruritus, and constipation. And again, those themselves, especially if you have IBD, can escalate other problems. There are many different screening tools available. Mainly, you can do this with your common sense. I think we know the patients that are asking for multiple prescriptions before they run out, are very fixated on where they're getting their opioids and getting them on time. And again, and their parents, and also we have to think about parent diversion here, and some of that is captured in some of the questionnaires they have. The screens are specifically patient-related. The soap is one that's available. It's free and relatively quick to use. When we're talking about patients who get into trouble, and now from slightly different perspectives, building on Dr. Kappelman's talk, central pain syndrome, so these are patients that in addition to their IBD have IBS and fibromyalgia and chronic back pain and chronic headaches. So chronic pains from other sources, high risk for opioid addiction. The psychiatric comorbidities you already heard about, history of substance abuse, including tobacco use, cannabis use, gateway drugs, making them slightly higher risk. The family history we talked about, childhood trauma, even if it's verbal, emotional trauma, increases a child's coping skills, more likely to turn to drugs as an escape, and then the problem behaviors we talked about. If we move on to chronic pain with no addiction, we want to taper the opioid, and we want to do it in a way that if it's an outpatient taper, you want to come down by 50% a week. If you bring them in for an inpatient taper, and we'll talk about that in a moment, you can bring them down as much as 25 to 30% a day with careful medical monitoring. You want to use any chronic pain needs a multidisciplinary approach, and we'll talk about what non-opioid alternatives there are for chronic pain. So doctor-patient relationship is key. Trust is key. Even myself, when I'm working with the patient, often weekly or every other week, I won't broach the idea of coming off opioids for at least a month to 3 months. So key to build that trusting relationship with the patient and not go at this too quickly, especially if they've been, some of the patients, even the adolescents that come to me, have been on opioids for years. Education about the causes of pain, the multidisciplinary approach we talked about. Once you've had chronic pain, it's much more helpful to talk about it in a rehabilitative, not a curative perspective, so that you're going to help them function in spite of the pain. Yes, there's ways that we're going to be able to make it less, but we've got to help you work with this in your life in case it doesn't get completely better. Of course, treating the comorbidities, the sleep disturbance, depression, anxiety. Cognitive behavioral therapy has the most support for treatment for pain, for sleep, for depression, for anxiety, with no side effects. You need to have somebody, and it can be nurses, it can be your office staff, it can be you as gastroenterologists, so it does not have to be a behavioral provider who reinforces the use of cognitive behavioral skills and can all have an impact in changing the behavior that's associated with going after the opioids for the pain. And then we have our pharmacological agents. So opioid taper is the ultimate goal. And one of the things that we know from children is the dose-response relationship for opioid dosing is less clear, less worked out. So you especially have to monitor for withdrawal, particularly anybody who's been on opioids for 14 days. Opioid withdrawal is horrible, and it's a very real physiological event, and if you don't monitor it, then those symptoms increase anxiety, angst, and often erroneously in the patient's mind make them feel that, look at how much I need this opioid. And there are ways that we can prevent this. Some of the strategies are switching from short-acting to long-acting opioids, and oxycodone and fentanyl are FDA approved for children. 10 to 20% reduction of opioid dose every 24 to 48 hours. Again, that's if you can have very careful monitoring. And during this period, even recommending bringing your kids back to the office every couple of days if you're the one managing this, or in their PCP's office. And again, I would recommend even a slower taper. And with a slow taper, you have more of a chance to get some of those cognitive behavioral therapy techniques on board. Benzodiazepines, so this is an area where I will use benzodiazepines short term, explaining it to the child and the family, taking the edge off anxiety. You've got to be very careful, though, not to replace one addiction with another. And so if there's a high already substance abuse history going on, then I would not use the benzos. And then the alpha-2 agonist, very effective for withdrawal. So they help with the physical symptoms of withdrawal. They also are calming, soothing agents, and they actually help with sleep. So something that I think we don't utilize enough. They're non-addictive, and sometimes the patients will stay on those even after they come off the opioids. Know your equivalents. We don't have time to focus here, but I think that even if you're not the prescriber, the more that you know about the opioids and the relative dose that your child that you're treating is on, the better you can help. For adolescents, so there are a growing number of strategies being used of how do we help opioid withdrawal, especially in the face of addiction. Buprenorphine is probably the one that is the safest, easiest to use. It's a partial agonist, works at the mu receptor, and very effective, and can also have some impact on the pain itself. You can also, by the way, it is something that you can do at home, so the patient doesn't have to come into a clinic, and they now are having even a sublingual form. And Suboxone is one you might have heard of. It's buprenorphine plus naltrexone, so that combination is very effective. You need to remember, go back to your medical school days and remember the difference between opioid intoxication and withdrawal. The pupils are the easiest way. And really, when you start looking at people's pupils, really look into their eyes, right? You're going to really tell quickly your patients on opioids. If they're in withdrawal, they're going to have large pupils. And if they're on opioids, they're going to have really small pupils. So start checking the pupils, especially if you're doing tapers. Other things with intoxication, you have hypotension, depressed respiration, bradycardia, and euphoria. Again, they can be subtle changes, but again, we're all graphing our different measures that you look for subtle changes. Opioid withdrawal. So early phases, you have the eyes water, you have yawning, you have runny nose, so release, sweating, restless sleep, goosebumps, irritability, tremor. So some of these you can see, but often you get them reported, and that's a nasty state. Nobody's going to be comfortable in that state, so we really want to be mindful of this, a slow taper and then treating the side effects of the agents that I mentioned. And then late phase, you can have increases in the physiological parameters. You can have nausea, vomiting. It's tricky because part of late opiate withdrawal is abdominal cramping and pain, and so often patients will mistake that for, see, I need the opioids. Well, let's keep working on what we're doing, and let's see how it goes. Really work with your patient to not put them back on the opioids. Muscle spasms, weakness, and even bone pain reported. So let's talk very quickly about what's available off-label. So of the antidepressants, having a noradrenergic part of the compound is really what seems pervasively across chronic pain literature to most directly impact pain and visceral pain specifically. So the tricyclics and the SNRIs, the serotonin noradrenergic reuptake inhibitors. The SSRIs are very effective in treating the anxiety and the depression, and you had a nice review of that with Dr. Busvaros. Mood stabilizers, gabapentin, pregabalin. One of the things, though, that it's really important to know in your area is what's reimbursed by the insurance plan your patients are on. So if some of these medications aren't reimbursed, it can cost your patients a couple hundreds of dollars to get these without being covered. So sometimes you have to work with your insurer for that patient to see what they'll cover. But really, all of the mood stabilizers have some FDA indication, or the ones that are listed here. So that is carbamazepam, oxycarbamazepine, and lamotrigine, and topiramate for some type of neuropathic or chronic pain syndrome. None of them have an indication for chronic abdominal pain. Quetiapine is something that at high doses is an antipsychotic. At very low doses, 50 to 100 milligrams, we found it very effective for pain, anxiety, and poor sleep combination. At high doses, you do have to worry about metabolic syndrome. Low doses, that is not an issue. Titrate one medication at a time. Start with an algorithm, starting with the medications you're most comfortable prescribing, low doses, titrate to either maximum benefit or intolerable side effects. And only use polypharmacy if the first agent you use doesn't work. And then really, I do the pharma because I know that's where a lot of the interest is, but the behavioral techniques really need to come first. And anytime you're prescribing any psychotropic medication, there needs to be a strong message that this is along with behavioral strategies. A biopsychosocial formulation is the beginning of any intervention. So really get your patients. A lot of education about pain. I'm going to whip through some slides to just show you the kinds of diagrams I use to educate. Mindfulness meditation techniques and mindfulness techniques woven into CBT, dialectical behavioral therapy, DBT, is another modality that really is growing in not only in practice, but the efficacy trials to support their use. All of these are psychotherapy, hypnosis, all of those things are ways that you can give patients control of things they can control. You're also teaching them techniques to calm themselves, to put themselves in different mind states. Those mind states distance themselves from pain. Here's one of the graphics that I use, so really emphasizing that pain is a brain event. The narcotics can dull that signal, but they don't teach coping skills. Mindfulness, what is mindfulness? Paying attention on purpose to present a moment experience in a non-judgmental and accepting manner. So you have to have discipline, which is sometimes hard with teenagers to get them to get in this state of this non-judgmental presence, and that then is a buffer to either negative thinking, catastrophizing, or aversive signals coming from your body. There is a study that came out that state mindfulness reduced pain response in adolescents, and the ones that practice meditation outside of that one-time, one-point experiment had a much stronger effect. So it's about motivating the adolescents to practice. Yoga has also has some growing evidence in irritable bowel pain, and again, yoga is just a mindfulness meditation, hypnotic sort of trance state induction, plus some movement. Cognitive behavioral therapy, I'm going to cover this one trial by Palermo. It was all-cause chronic pain, 11 to 17-year-olds. It's a web-based design, and they had separate websites for parents and for kids. Parents have to be a part of all treatment, but especially when you're dealing with pain. And so the teens do these modules. They log 30 minutes a week, so they really are very realistic in what they're asking the kids to do. The total treatment duration is 9 hours, 4 hours of parent work, 4 hours of work with the child, and a lot of this is done online. So it's a very clever website. And they have this program travel theme where each time you go and do a module, you get another stamp on your passport. It's really all of the classic cognitive behavioral techniques that you heard about earlier, the giving activities to distract, cognitive reframing, and then a lot of relaxation techniques. And then you have a message center. So it's brilliant. I tried to contact the authors if it was available, and they haven't gotten back to me, so I would have all of you email them. It should be available because they use federal fundings. And again, some of the specific things that are covered. They had a significant, first of all, engagement. 77% of youth completed all 8 modules, and they had a significant reduction in activity limitation and pain intensity 3 months later. So if there was one place that I would go explore further, this would be the study. And again, in ending, a multidisciplinary approach is important. The last part that I have just in a few slides, talking about chronic pain and addiction. So here, same techniques. What do you need for addiction? You need to have drug counseling. This is outside anybody's purview here. You really want them hooked up with somebody that treats addiction. You want them to tap into groups available, Narcotic Anonymous for teens. They have them in most cities. You want to think about how you and the parents can start working with removing contextual cues that might be linked to their wanting, craving the narcotic, obviously family caregiver involvement, and then a lot of motivational interviewing, getting kids to develop ambivalence about using these substances. This is my last slide because I always get asked the question about cannabis. What's the data out there? So, I don't know, fortunately or unfortunately, there is some data in adults that it can lead to improved abdominal pain, cramping, joint pain, and diarrhea. However, it's one of the strongest predictors in Crohn's disease patients of future surgery. And for kids, and this is key, and this literature is just coming out, luckily, very strongly in other literatures, neurocognitive deficits, diminished driving performance, increased risk of future substance dependence, and then even with just as chronic use as 1 month, paranoia, lack of motivation, and depression. Meperidine, really nothing significantly helpful or endorsing its use has come out, but I think this is just to leave you with, while I know a lot of our patients use marijuana, the jury's not completely out on the efficacy, and right now the risks are way outweighing the benefits, and CCFA's official stance on this is to ask your kids not to use marijuana, or at least not endorse it. Thank you.